Good morning, everyone. Sorry for the late arrival of this, but let's get back into it. Chapter 22, minimally invasive surgery. Where we left off, we were talking about some of the advantages of minimally invasive surgery and some of the limitations or disadvantages behind it. What you see in these pictures here, these are examples of the trocars. When the inner obturator is loaded in to the cannula, the whole thing together is known as a trocar, but those are the pieces of a trocar. As you have this inner obturator and the outer cannula, and the cannula is what gets left in. Obturator gets removed, and then you can pass instrumentation down this tube from the outside of the patient to inside of the patient. And like we talked about, some of the limitations, it's a steep learning curve. If you're not familiar with, looking at a two-dimensional screen and working your hands to make instrumentation do what you want it to do inside the body, it can take a while to kind of get used to that and get used to the feeling of how it works and things like that. So now some of the risks associated with minimally invasive surgery is, it's not really any different than doing it open versus, like laparoscopic or minimally invasive. They're still working on the same area, things like that. You can still have the same kind of complications. It's just as long as we, do what we're supposed to do as far as, making sure our instrumentation is working properly, things like that. Maybe even the condition of the patient themselves. Is it a larger patient, or do we have them positioned correctly? Are they right kind of bed? For the type of patient that we have, is it a bariatric patient? Do we have them on a bed that's not rated, for their weight and things like that, or whatever? Do we have enough CO2 in their tank to do a procedure? Right? Are we working on a joint or in the bladder where we're using irrigation, and because maybe we as the tech weren't prepared and didn't have everything that we needed. Now the nurse is having to run out of the room a lot to go and get things that we don't have, and now isn't paying as much attention to the irrigation bags, or isn't there when the alarm goes off on the insufflation machine to say, hey, low gas, and then we lose our visual field and things. So, and then of course, equipment failures, right? Where it's the number one way that fires start in the operating room, usually electrical, right? Some kind of electrical equipment failure. So kind of prepping the patients for these cases, minimally invasive, especially laparoscopic or, and otherwise, like thoracic and joint surgery and things like that. There's different positions that we have to put these patients in. This is what we're going to go over in lab this coming week as a kind of a side thing, while you guys also practice your scrubbing and gowning and gloving each other and things like that. We're going to be going over positioning of the patient and why we need to position these patients in these certain positions and things like that. And but we also need to consider comfort of patient and things like that. And and then that also is going to cue us into the area we need to prep this patient in, right? Depending on what we're working on, the position they're in, and how we go about accomplishing that prep. But any kind of minimally invasive surgery has the potential to become what we call an open procedure. That's where we make a large incision and open the patient up. Most of the time when we're talking about, hey, we had to open them up, we're referring to the abdomen. But that could be, any number of things. Like, you could be doing minimally invasive surgery on the spine, and it's just not, you can't get in the place you need to get to or whatever. So you just like, okay, forget it. We just need to open this up. We got to do it usually happens very quickly. As soon as the surgeon decides, hey, we need to open this patient up, they're removing all the minimally invasive like cannulas and equipment and things like that and putting it on your Mayo stand and asking you for a 10 blade. So communication is key here, especially with your circulator, because they're the person who's going to need to open some things to you, right? You got to switch out your instrumentation, and sometimes if you don't have a major tray already on your field and you got to get it up, those instruments still have to be counted, but you still have to stay in rhythm with the surgeon and helping things get over. Sometimes it's an emergency that you have to open, right? You get in there and something gets nicked, a blood vessel or the liver or something like that, and it's bleeding, and you need to open it up so we can deal with that bleeding. This comes with practice, and usually also comes with getting kind of burned a few times, not having the open stuff on your field and ready, and having to play that catch-up game for the remainder of the case. Not a whole lot of fun. This is an example of what you see as imaging systems, right, that we use in minimally invasive. The system itself is everything that you see. This includes a light source, a light cable. The light cable is going to be sterile and come from your field and plug into the machine. You've got the actual scope itself, right? You have the camera box or the camera control unit, video cables that are connecting one tower to what's called the slave monitor or just monitor screen. And then you have an image management system, which is basically like a hard drive. It's a computer system that stores all the images and video recordings and all that stuff for later access. You can burn down to DVDs. You can print out those pictures to show the patient what you saw inside of them. The light source is a fiber optic cable, which means that when you are handling it, you have to be very careful with it. You can't set anything heavy down on top of it. You're going to break the fiber optic cables inside, which then it won't be able to transmit the light through it. When you're wrapping it up, you're just coiling it. You're not wrapping it real tight around anything because, again, you're going to break those fiber optic cables. And you'll see it too. Ones that are broken, you'll see little sparks of light that are shining inside the cable. And over time, it's not going to come out the end anymore. These also have to be handled very carefully while on the field because that light that's coming off, it's going to be extremely hot. So you don't want to touch that area with your bare hands. You want to put like your finger over it to like block the light because it'll burn through your glove. And you don't want to set it down on the drapes or anything like that because it's going to be a source of ignition. Definitely. And then sometimes, the bulb inside the actual light box itself that's producing the light, that'll burn out. So we have special replacement bulbs for those that we usually keep in the core. The rigid telescope. This is the actual scope itself that goes inside the body through the cannulas. Right? You have ones that are what are called 0 degree, which means you're looking straight ahead. Right? Then you have the more typical ones are like your 0, 30, and 70 degree. Those are the ones you're going to see most often. 30 degrees means that you're looking, like if I was to be looking straight ahead, actually I'd be looking 30 degrees downward. And I can actually turn that scope. So then if I kind of turn my head this way, now I'm looking 30 degrees off in this direction. And you can do that in a 360 degree. And the same thing with 70 degree. Now I'm looking more down here. The reasoning behind all of that is when you get into a dome-shaped area, like when you distend the abdomen with insufflation, with the gas, you've now created like this dome inside. So you need to be able to look all around the dome and be able to see all the different structures and organs and things like that. Same thing's true when you're inside the bladder. That's why you're going to see the 70-degree used more often in the bladder because you need to see more near the bladder neck. And that's where you're right going in with that scope. So sometimes you need to see that back side of it, looking for kind of like tumors and things like that. But here's another example of the rigid telescope and that kind of field of view that I was talking about here. Just you got the 0 degree, so you're looking straight out. That 30-degree more down, 45 would be even further. And so your eyepiece, this is where your camera is going to connect to, is right onto the eyepiece right here. And your light cord attaches right here. And it sends the light down the scope here, and then your camera is recording the image that's coming back and putting it on the screen for you. These are also very delicate and extremely expensive to repair and replace. So the cameras, the light cords, and the scopes all get handled with care, and they're all hand washed items. They do not go in the steam sterilizer. The steam sterilizer will destroy all the components. Um, what you see here on the screen in the little pictures, uh, that's what's called FRED. It's anti-fog. Some of you in lab, if you remember, you were talking about trying to find ways to defog your glasses and things. This is something that we use on the field to prevent fogging. When you are handling the scope, you're going to carry it by the eyepiece end. This is the heavier end. You don't want to carry it down here because you can cause little micro bends and little fractures in the fiber optics inside the scope. You're trying to prevent any scratches or anything like that on the tip here, and then any dents along the shaft of the telescope, because that again is going to break up those fiber optics and prevent light from shining down in. You want to use a lint-free material. Typically, our sponges, laps and Ratex on our field, those are all lint-free. So that's what you use. And these the sponges here that come in the little package of Fred, those are also lint-free. So what you'll do is you'll take that liquid and kind of soak that sponge, and then throughout the case, if something like blood or fluid or something like that gets on the end of the scope, they can pull the scope out, clean it off with the sponge, rub it in the Fred, kind of give it a little wipe and go back in. And then that Fred will help keep that fog from happening. And if anyone who doesn't understand how the fogging works is whenever you go from an area of cold into an area of warm, and it's a big difference, you get that condensation on on your objects, and you've seen that on your guys' glasses, right? You're breathing, and it's the hot breath coming onto the cool lens of the glasses, and that's what's causing the fogging. So this prevents that because then the warmth never reaches the lens. It's got a protective kind of film over it, so it never fogs it up. But that happens because we're bringing that scope from the outside in the operating room where it's anywhere from 68 to 73 degrees, right, Fahrenheit, and putting it inside of a human body, which is at least 98.6 degrees, right, somewhere around there. Right? Some people run a little cooler, 97 degrees or whatever, but that's about a 20-degree little more difference. Right? So you can see where that would fog up. Another way that we also prevent fogging is we use scope warmers. They look like little thermoses. We'll fill those with warm, sterile water and then put the scopes in there and let them sit in there until we're ready to take them and actually insert them in the body. That way they're up at about the same as body temperature already, so there shouldn't be any fogging. This here is the camera, right here this is the camera head. This is what's known as the endocoupler right here. You push down on this little black spot and it opens this circle a little bit more inside of here, and it connects right onto the eyepiece right here. And then when you release, it kind of locks onto it. The focus ring is this little silver piece right here behind it. That turns and focuses your image. Right? So if it's a little blurry or fuzzy on the edges of things, you can kind of turn that a little bit and it'll sharpen the image up for you. You can replace this camera control unit. This piece right here can actually screw off from the silver part. You can disconnect these into two, but you handle the cord the same way. You're gonna not wrap it tight, but kind of coil it up, things like that. Um, the camera head has a 3-chip camera. It's what it's called. This gives you a nice color image in the red, blue, and green spectrum. That's how it gets that name, the 3-chip camera. It's the red, blue, and green. So now you get natural color images, so you can decipher between what's the liver, what's the gallbladder, without having to like know exactly what the like shapes of the anatomy and things like that. You can tell by color now too. It looks more natural. Um, like a real image, the 4K quality type stuff. Um, white balancing. White balancing is where when you first go in with the scope, you need to get that color like calibrated. So what you do is you'll either hold up uh, one of your sponges when you're outside of the body, and then you can hold the white balance button on the camera head. And one of the buttons back here is you push and hold it, and it'll white balance the image right up against the white sponge that you're holding up, or you find some white tissue inside the body. This is inside of a knee, the meniscus and the cartilage of the bone, and you press and you hold it, and it kind of balances out all the image. It calibrates all the coloring so that this is the image of somebody's hand. They're got their hand kind of wrapped around the end of the scope and just took a picture. But that looks more like the color of skin instead of like a more grayish is what it would show up and be like dingy. The video cables, right? That's sending your signal. You have the one main tower, and then you have what's known as a slave tower, which is just it's another tower that when you connect those two images, you're just sending the image over to the other monitor and having dual monitors so that the surgeon standing on one side of the table can look across the table at his monitor, and his assistant can look across at their monitor and see the same thing. And that way, no one has to kind of like turn their head or tweak their back or something like that while they're working with instruments on the field to see one television monitor is what's going on. The output recorder, that's part of that video system, the computer, onboard computer that's recording and storing the images and things like that. Obviously you have your monitor screen, and then the reason we put them on those carts and everything you saw in the image, right there, is now we can roll this whole thing into an equipment room and then line up, multiples of them up against the wall or whatever. And we're not having to like pull out every single one of these boxes and drag a couple of these into the room and things like that. And they've designed also some operating rooms now that, whereas you guys have seen in the lab when the lights come down out of the ceiling, they have another things that they call booms, where they just have these big shelving units where you put those uh, boxes and things on like that, and you have other monitors and things like that that are coming down from the ceiling, and it's all like wirelessly connected. So and then those rooms are designated as being like laparoscopic or sports medicine, orthopedic, where you're going to do all your scope, your joint scopes and things like that in those rooms. You have some specialty type scopes, right? There's a resectoscope. That one's specifically used in urology to resect the prostate for enlarged prostates. Laparoscope, that one's going in the abdomen, right? Arthroscope, arthro meaning joint, that one's going in the joints, right? Hysteroscope, hyster being uterus, so that one's going. We can actually scope inside the uterus and see what's going on. Thoracoscope, that one's going in the thorax or the chest, right? We can go into the pleural cavity and look at the lungs and things like that. Nephroscope, nephro meaning kidney. We can actually put a scope into the kidney and look inside the kidney and see if there's any like stones and blockages and strictures inside the uh, the connection in the calyces and the connection into the ureter and things like that. And then the cystourethroskop, this is one that's going to go from kind of retro into the urethra, back into the bladder, and then you can get into the bladder that way and find bladder tumors, or you can work on stones that are stuck in the ureter, things like that. And then all of these have like different lengths and diameters. Usually, you're looking at like a 5 millimeter diameter to 10 millimeter diameters on a lot of these scopes. You have different channels so you can feed instrumentation down them. They have ways where you can hook up the bovie to instrumentation or onto the resectoscope itself. You actually hook the bovie up to. That's how you resect away tissue from the prostate. They all have different little channels and things like that, and you get to learn what each one's for as you do those certain procedures. And then some of your instrumentation here in the picture, you can see you've got things that grasp and hold. You got things that cut and dissect. You also have ones that are for visualization and exposure that can retract and hold other tissues back and out of the way. A lot of it for minimally invasive, especially in the abdomen, for retraction and the visualization exposure piece, is your insufflation and the positioning of the patient. But there are some other retractors that you can use, but they can all be in three kind of different categories, right? They can be reusable instrumentation, like that's what you see here in the picture. They can be disposable, right? Some of these ones, like some of the scissors, we have disposable tips where you just screw the tip of that scissor off and throw it away in the sharps. And then for each new case, you're opening up just the tip of the scissors and then screwing it onto the end. That way it's a fresh, nice, sharp pair of scissors every time. Because if you get into having dull scissors on tissue, instead of just cutting it, you're going to like chew at it. And it's not going to really cut very well, and you're going to cause kind of more damage than what's necessary. Then you've got disposable things that you can use for minimally invasive that after the case is over, you throw in the recycle bin or in the trash. Like our staplers and clip appliers and things like that, meant for clamping and occluding. And then you also have ones that are reposable, where you can change its shape. We have certain kind of retractors. There's one that's a snake retractor, and it goes in and it's straight, and then as you twist the dial, it kind of snakes up into kind of a cobra format, and you can use that to kind of retract the liver. They have all kinds of different. You got ones that fan out for retraction. You have your staplers that you can kind of turn in certain degrees and everything like that, so you don't have to come straight at something. You can kind of come off to the side if there's other tissue and things like that blocking your path. So there's all different kinds of things that they've come up with to kind of help deal with situations that we've come across doing this minimally invasive type surgery. But like I said, you have all your categories, right? You've got retractors for visualization exposure. You've got things for grasping and holding. You've got things for cutting and dissecting. Your clips and your staples are your clamping and occluding. And then you also have your suction tips, because you can, when you irrigate inside there, it's all going to kind of pool up, right? It's like filling a pool, like a little kiddie pool, or a bird bath, I guess, would be more closer to the size. But then you're going to need a way to get that out. So we have special tools called a suction irrigator that as you push one button, it shoots irrigation saline inside that we have hooked up to an IV bag. And then when you push another button, you can suction that back out, and it comes out a different tube, and we have that hooked up to our suction. So a lot of different cool, crazy little tools that we have to get kind of through these minimally invasive type surgeries. endoscopes and the resectoscopes. The endoscopes we kind of talked about. Those are those flexible, um, uh, one that goes like down the throat, right? The esophagoscope, and then the colonoscope that goes up the other way. Right? The resectoscope, that one's a rigid scope, um, and like I said, it has that cutting instrument, a little loop, uh, bovie tip that you can kind of hook onto it. That's also in conjunction. It's like connected to the telescope itself, all in the instrument. And as you open and close it, that loop comes out so you can see it directly in front of you on the scope. When you bring it back, you're cutting that tissue so you can see exactly what's being cut and you follow along the whole time. Um, this is the insufflation, right, for laparoscopy. Uh, the A picture there you see is before insufflation. B, after we've pumped the CO2 gas into the abdomen, we blow it up like a balloon. That gives us our room to see and work and things like that. It's what's referred to as a pneumoperitoneum, right? Air in the abdomen. That's what it means. There's a few ways to go about doing it. There's the Varus needle technique that gives the saline drop test. You're going to make a small stab incision with an 11 blade, and then you'll take this needle, a Varus needle, um, that as you push down, when you first see it, it looks like it's rounded at the tip. But when you push down, that rounded tip kind of retracts against pressure, and an actual needle pokes out. And you just poke that down through the skin, and as you get through and that pressure is no longer on there, that blunt piece pops back out so you don't accidentally poke into anything inside the abdomen. And then you'll take a 10 millimeter syringe or milliliter syringe that's filled with saline, and you'll hook it up to the luer lock end of the Varus needle, and you'll slowly inject the saline and then disconnect it. There's a little stopcock on the Varus needle, and as you turn it, you'll see the little chamber empty because that means you're through, and it just drains into the abdomen. It's just saline. And then the picture you see here, this is your insufflation tubing. The end that's got this little filter is the end that you pass off to the circulator that gets hooked up to the insufflation machine. And then this end here gets hooked up to the Varus needle, and then you start pumping the CO2 gas in until you get it distended or blown up like this. For continuous irrigation, this is typically when you're working on the bladder or you're doing hysteroscopies or arthroscopies, places that already have fluid that lives in them. So we want to replace with what we're using with kind of a natural thing for that area, right? So these are usually like glycine, mannitol, sorbitol, or even saline. The reason we use like the glycine, the mannitol, and the sorbitol is that they're not as reactive to using the bovie, using the electrocardiogram. And we want to try to use what are known as isotonic solutions, which means that they're kind of made up of the same stuff that our own body fluid is made of. It's as close to that as we can get so that the body doesn't see it something that's foreign and start to attack it. And then it builds up this inflammation process starts while we're even, performing the surgery, and we don't want that to happen. There are times that we do change the tone of our fluids that we're using, but we do it purposefully, especially when we're going after like cancer cells in the breast, things like that. We'll actually irrigate that area with water in an attempt to kill any cancer cells that were left behind. It'll also kind of take out some of the healthy cells that are in the area too, but that way it catches any one of those little cancer cells that is left behind. And then for keeping track of how much fluid gets used. That is the job of both the surgeon and the circulating nurse, is to monitor the fluids and how much was used, because we need to keep it kind of an accurate, what went in should be what's come out, especially for hysteroscopies. Uh, we can't be leaving a lot of fluid behind, because that's going to leak later and cause a problem, and it may get trapped inside the uterus, causing an infection as well. This is that balloon dissection that I was kind of talking about before with inguinal hernias. They kind of go into the space right into that spot, into the triangle. There's a triangle that's made up by the uh, umbilical arteries, the inguinal ligament, and a nerve right there in the inguinal area. But this goes into that space and just already frees it up, so that when they go in to repair the hernia, it's already kind of shown for them, and they know exactly where to go. And then in hemostasis, right, where we can use electrosurgery, right? We can hook one of these instruments up to the ESU or the bovie, right? We can actually suture laparoscopically. There's an instrument that I'll show you in lab called the endo stitch. That at the very tip of it, it's got a horizontal needle that magnetically just passes the tip back and forth between the two ends. So you can poke it through tissue, close it, change the magnetic over to your right part, and when you open it back up, the needle's going to pull through that tissue with the string attached to it. And then you can tie your knots and everything, and put in scissors and cut. There's also ultrasonic technology. I'll show you guys that, the harmonic scalpel. It uses mechanical means. It moves back and forth. It vibrates so fast that it's able to cut through and seal tissue, just like that. So minimal bleeding, very effective, and decreased surgical times greatly. Here's that trocar cannula system I was talking about. Remember, all together, it's a trocar. This is the obturator, is that inner piece, and then the cannula is this outer piece that the obturator plugs into. Right? They use them for laparoscopy, arthroscopy, thoracoscopy. They come in different sizes, right? We have disposable ones. We have metal reusable ones when you're doing robot cases. You'll have the metal ones because those are specifically designed to dock into the robotic arms, things like that. You have ones that you can kind of change the shape of and move around, like your Hassan trocar. Sometimes when they're going into the abdomen, into the belly button or the umbilicus or umbilicus, they put in what's called a Hassan trocar, and it's got a special kind of pyramid bottom to it that helps hold it in place, and they suture those down to keep them in place, because they're going to be going in and out a lot with the scope and instrumentation and things like that. So the Hassan trocar is usually a 10 to 12 millimeter in diameter trocar, but the ones you saw back here on this slide, these are all 5 millimeter. This one might be a 10 off to the side, but these two here are 5 millimeter trocars. So they make relatively small holes in the abdomen, or in the into a joint space or something like that. But it's just enough to fit your camera and a couple instruments in, so they can do some work. Typically, your 5 to 8 millimeters you're going to be using on your pediatrics, although we do use the 5 millimeter on adults, but typically you're going to have one that's at least a 10 or a 12. And then your large, or anything that's like maybe like a specimen retrieval, or you need to put in like a stapler or something like that, you must have a 12 millimeter trocar or cannula in order for you to use a stapler. A stapler will not fit through a 10. So it must be a minimum of 12 millimeters. But these are the different sizes, and it's all depending on the type of instrumentation you need to use. I mean, are we doing some staplings? Then you have to have the 12. Does the surgeon like using the 10 millimeter scopes, or do they like using the 5 millimeter scopes? Are we doing an appendectomy? Are we doing a lap chole? For the lap chole, are we doing it because the patient has stones, or because the patient just has a kind of a dysfunctional gallbladder that may change up uh, the sizes? And you have multiple trocars and cannulas on your field because you have to put in at least three to four, depending on the case that you're doing. So, and then like those placements, it's according to what you're working on, right? If are we working on the gallbladder, then we want to put a couple of our or ports, kind of off to the left hand side, and then a couple down here so we can grab onto the gallbladder and hold it up while we work, across. Are we working on the appendix? So we want to put them all more on the patient's left because we can see across to the right. Are we working on the spleen? We're working on the lower part of the intestine. Are we working on, whatever we're working on? That's going to depend on where they place those. Because what they don't want to happen is a lot of sword crossings and having to fight with each other and and being able to have still a good visual field, but be able to come in and comfortably work and not have to fight. Even standing next to one another and pushing somebody or leaning way over the patient or something like that to get across something. They kind of strategically what is called triangulating their shot, basically. And then here's an example of specimen retrieval. What you see there in the picture is called an endo catch bag, and that's just what it does. Is you push it down, it opens up like that, a little bag. You shove like an appendix or a gallbladder or an ovary, something like that, into there. And then as you pull back on your end, it's going to cinch that up like a little purse and holding that specimen inside the bag. And then you just pull the whole thing back through the trocar. Morcellation is where you actually like cut an organ into like strips. So say they wanted to remove a uterus laparoscopically through the ports. They would have to cut it into sizable strips. And they have special instrumentation that morcellates it and makes it easy, so you're not there with just like a little pair of scissors trying to cut through it or anything like that. But it becomes kind of a big time hassle because you take a strip and then you got to put it in a bag and put that strip in the bag and take that bag out and get another bag because the bags are only a one time use. And then like the tissue shavings, that's the like prostate resection, things like that. And usually you're using like the irrigation, the Elic evacuator to get that stuff out with. And also in the tissue shavings are also in arthroscopic, where they're using the shavers. What the circulators can do if the surgeon wants to shave or send that shavings off to pathology is they can put what's called a sock. It's like a little mesh bag on the lid of on the underneath side of the lid of the suction. So act kind of as a filter. So as the fluid comes in, the fluid goes through the fine mesh bag, but the little shavings of tissue and stuff don't. So at the end of the case, they just disconnect that little bag and put that whole bag in the specimen container and send that to pathology. Some of the risks, right? Again, insulation failure. And we're talking about the instrumentation that we're using, where the insulation around the outside of that instrument is cracked or become frayed, just over use and cleanings and being re-sterilized. I think it's just gotten old and things like that. And now you run the risk of burning patients and tissue. Right, you're using that instrument to burn some other tissue, and that burning should only be happening at the tip. but you got a little break in insulation back near the handle, and that, or not near the handle, but a little further back from the tip, and that area is touching another piece of tissue. That's known as direct coupling, right? Where now some of that electricity is going to that open spot and it's burning tissue that you don't mean to be burning. Capacitive coupling is when now it starts kind of arcing off and finding a nearest path. And what usually will happen is that the power that you have at the tip is diminished because it's coming out of another area. And the surgeon still doesn't realize that's what's going on because you can't see it on the scope. It's off of your field of vision. You don't know that's what's happening. So they ask for the bovie to be turned up. They're like, I'm not getting enough power here. They're thinking that the tissue is a little thicker. So they need a little more power to burn through it. So that, hey, can you turn my bovie up? And then all of a sudden they jack that bovie way up and they're still not getting the right thing. They're like, I guess that's better. But all the while they're really destroying whatever tissue is off to the side. So it's up to us as the techs to kind of inspect these instruments when we have them on our field before we start the case. You just kind of give them once over and make sure everything looks good. You don't see any cracks or any exposed like metal and things like that, especially on those instrumentation that you know they typically will hook the electric cautery to. But here's some of the ways you can reduce that risk, right? Make sure you're using the right cannula. You're not trying to shove something in, that's supposed to be for a 12 millimeter, and the doctor doesn't want to take the time to change out his 10, so he just takes it and kind of shoves it in, and that can break up some of that insulation and damage the instrument and things like that. There's not an issue with the power setting, right? That it was reprocessed properly, right? That it wasn't put into some other liquid. And now if there's some rusting or things like that that's going on internally, that your cord is connected correctly, things like that. That you don't have any kinks or knots in your wires and stuff like that. And you're not letting your cord sit into puddles of water or saline or whatever fluids on the field and things like that, and then trying to hook it up. Kind of a basic electrical safety, right? The ultrasonic, right? That's that mechanical using to coagulate and kind of seal tissue. Bipolar. Bipolar is it gets hooked up to the same machine that your bovie pencil gets hooked up to. And your bovie pencil is what's called monopolar, which means that the energy, the electricity, starts at the machine, at the ESU, travels down the wire that's connected to the bovie pencil. And when you push the button, that electricity comes out of the tip and into the patient. And that electricity travels through the patient to the active electrode or grounding pad and goes into the grounding pad and it follows the wire back to the electrosurgical unit or the bovie machine. Bipolar, the electricity goes from the machine down the wire and only goes down one side because these bipolars, you have two ends. So the electricity is only going to travel down one side and then through the instrument into the tissue and then across to the other side of the tip of the instrument and then travel back up that side to the wire and back to the machine. So you do not need to have a grounding pad with bipolar because it never travels actually through the patient's body. It only goes through the tissue you have in the grip of the forceps or the instrument that you're using as bipolar. Lasers, right? Same precautions that we already talked about when we talked about hazards, right? You have that bucket of water all your drapes and towels and everything like that that surround the surgical site will be soaked in water or saline. Usually it's water, uh, so that you don't accidentally catch anything on fire. Uh, but to prevent those fires, that's what we're looking at with the lasers. And then also eye protection for the patient and for those in the room. No reflective instrumentation, things like that. Um, and then we also have some suture, ligature type devices that are used laparoscopically. Um, but you need to understand the difference between an extracorporeal knot and an intracorporeal knot and kind of the techniques. Uh, all it means is, if you know what corporeal means, it just means body. And extra means outside the body, and intra, inside the body. And all it's referring to is, where did we start tying the knot? Did we tie the knot outside the body? Then it's extracorporeal. And you have to use what's called a knot pusher to slide that knot down one side of the suture in through the cannula and then into the body and then tighten it down. But you tied the knot outside and then slid it down. Intracorporeal means you're tying that knot inside. So now you have to use two grasping instruments to tie that knot inside the patient, rather than tying it with your hands outside and then sliding it in. Intracorporeal is now using the instruments to tie it. Here's some more examples of these. Rigid. Most of these are graspers, but you have different types of graspers. You got ones with big giant teeth, kind of like your coker, right? You have nice and smooth ones that are used for grasping onto like intestines. You got Pennington style ones for grabbing onto uh, like the lung and things like that. You got ones that are like scooped, more like stone kind of grasping, right? Kind of scooping up stones. You have traumatic, atraumatic, just like you have in your regular open instruments. They're not any uh, different than what we already have. It's just now they're going to be long and skinny because we need to go down these trocars. Right? Times that we inspect our instruments, right, is before we're going to use them. So as we pull them up to our field, right, and during use when they're handing them back to us, did something happen to them while they were using them, right? After use, when we're breaking down our field, right, we're marking those ones that got damaged that need to be looked at, things like that. And then after they've been decontaminated, right, after they've gone through the washer sterilizer or anything like that, we're looking at them, and while we're washing them, right, we're looking, inspecting, things like that, and definitely before, while we're putting the tray back together, before we load them into the sterilizer to be sterilized, because there's no reason to sterilize an instrument that doesn't work. You're just going to cause frustration and stuff for those people uh, involved in doing the procedure. The surgeon's going to get mad, they're going to get mad at the tech, and then the tech's going to be mad because they're going to feel like they got set up. It's just a um, bad cycle. Right? What you're checking for the work, open and close, right? Do the scissors actually, usually what I'll do is I'll take one of my little labels and I'll just make like a small cut with the scissors to make sure it's actually sharp and cuts. Do my tips all meet, right? Are they all straight? Is anything, bent? Is there any breaks in the insulation on the outside? That stuff like that. Is there any blood stuff still left in it? Did it get cleaned properly? Right. And then as you get these instruments back from the field, you kind of clean it as you go. You have a wet sponge, and it's just like a moist sponge that you just kind of wipe the tip off and then set it back down on your mayo stand. And that's kind of that. This is where your reprocessing starts, is point of care cleaning. Is you're kind of cleaning as you go. That way, uh, when it gets into decon, there's not as much to scrub on those and clean off, things like that. Your endoscopic instruments or laparoscopic instruments, they're usually going to come on like a rack, because these are all real long with like pistol grips and things like that. And it's easier just to kind of keep track of them on this rack. And you can just pick them off the rack and hand them up and stuff like that. You should place your scopes like on a towel so that they don't get scratched or things like that. They're protected. There's that thermos I was talking about that you can place your scopes in to kind of pre-warm them up. If you're when you're securing your cords to your drapes, because all these cords have to be passed off, one for the camera, one for the insufflation, one for the light cord, your bovie, your suction irrigator. You got a lot of stuff these cords are going to be being passed off. So you're going to have to kind of like tent your drape up around these cords, but you can't use a penetrating towel clip to hold it. So you're going to have to use something that's not going to tear a hole in the drapes. And then you got the right cord. You're passing off the right end of the cord, right? For your light cord, you want to pass off the end that plugs into the box, not the end that plugs into the scope, because they're two separate ends. And there's no way to get back the right one. If you've already passed off the wrong end, it's now contaminated. You need a whole new cord. When you're passing the instruments, you're going to kind of hold them near the tip of the instrument and offer up the handle to the surgeon, and then always kind of with your tip pointed down. So as soon as they take it from you, they can just go straight to the cannula and go in, and they don't have to move it or turn their hand. A lot of it's all about that position of use when passing instrumentation. You want it in their hand in the way that they're already going to use it. And then we typically turn the lights in the room down, or if not off, and just have kind of one little lamp or something in the corner for some light, so that everyone kind of focuses on the screen, and it helps you to kind of focus in on that and see everything a little bit better. You don't have the glare on the screens and things like that. So we can actually see what we're working on. Right? Flexible endoscopy, right? This is those through the mouth, through from below, where we're going to do like biopsies, or we can actually visually see something that's going on. Maybe a patient has an obstruction. What's causing the obstruction? Is it the actual tissue itself is narrowing down, right? That's what's referred to as like a stricture when your own body is doing it. Or is there something in there that's not supposed to be there? Did they eat a lot of sunflower seeds and swallow the shells for a great number of years, and now all of that's kind of backed up and created this kind of cork inside? Things like that. Right? Do you have varicose veins inside your esophagus? Do you have cancerous tumors? And this is all what we're looking for when we're viewing, and then we're taking biopsies of tissue to find out what's going on. Reprocessing the scopes and instruments, they're all hand washed items. They can't handle typically the heat, except for I think maybe the new robot instruments can now go through the washer sterilizer. But they get hand washed first and rinsed out. They have many different channels to them. Then they get placed in the ultrasonic cleaner, which uses cavitation, vibration of the fluid that's in there to break up the bioburden on the instruments. And then they also get put through the washer sterilizer. So they go through a very rigorous cleaning process for the robot instruments. But the scopes, the endoscopes, so the way that you do the reprocessing of the endoscopes, or the colonoscope, the esophagoscope, is you're going to have a dual sink. One side is going to be filled with, the warm water and the detergent. The other side is going to be just warm water. On the first side, you have it all hooked up to the flush. You have a special connection thing that goes onto the scope that flushes all its channels, and you're going to feed the brush down all those channels and brush it all out and clean it all out and clean the outside of the scope, and I'll do all the hand scrubbing, hand washing, cleaning all the stuff. And then you're going to move that whole scope over to the clean rinse, just regular water. And then you're going to perform what's called a leak test. So that special thing that was hooked up for flushing out all the channels is now also going to test the internal integrity of the scope itself and make sure that there's no leaks or any potential areas of weakness or anything within it. And then you'll drain all that water, rinse it one more time, disconnect uh, from the leak test monitor, but leaving that special attachment on. Then you'll move it over to the high level disinfection machine, uh, which is kind of like a Steris machine, which we'll get into also. But it takes it, like immerses the entire scope in disinfectant and like alcohol. Or that's not, I don't think I think alcohol is at the end when you're testing the effectiveness of the disinfectant. But then it goes through all that, and you hook up that special uh, channel flusher and everything, all of that, so it flushes through all of that. And then when that process is over, is when you can take it and hang it in the cabinet for, I believe, 7 days. And then after 7 days is up whether that scope has been used or not. It has to go back through this reprocessing thing where you flush it all out, clean it, leak test it, put it through the disinfection again, and then get to rehang it. Robots. So robotic surgery uh, makes it a little bit easier. It's now kind of computer guided, right? The surgeon doesn't have to be scrubbed in the whole time. Um, kind of saves on them a little bit. It also gives us that minimally invasive advantage, uh, and it also has a few other advantages which we're going to get into. Um, the robotic movement itself has a bunch of different articulated sections, and articulations just mean like joints, areas that where it can kind of bend and twist. Also, it can also go in like 360-degree. And that's what this Cartesian coordinate geometry is talking about. Is not just an x and y axis, but also the z axis in 3 dimensions. Right, that's that spatial dimension and things like that, and gives you a lot more rotational ability and movement and things that are a lot closer to what we can do with just our regular hands, right, and do with our own human body and stuff like that. So, like we can grasp onto something and move it down and to the right, right? Whereas, with a grasping instrument laparoscopically, you can grab it and pull it down, but then you gotta kind of like fight to move it to the right. And here you've got all these different articulations where you're not moving your fulcrum, your base point. You can just rotate around and things like that. So it's one of the advantages that robotic surgery has given is better articulation and fine motor control. Um, their design is based on how they move, right? Are they set up more for giving us guides, laser lighted guides of where to make our cuts for like uh, total joint surgeries, or are they more for actually manipulating tissue and things like that, and how far they need to reach within the abdomen, things like that. Like the Da Vinci system is one of those abdominal, pelvic, thoracic type robots that's doing a lot of the work and things like that. Some of the other ones for orthopedics are like the Mako, things like that are meant more for making those cuts in bone and making more precision type uh, cuts into this bone so that the implants fit better, and it's almost like nothing was ever done to those joints and things like that once the patient is recovered. Um, and then you also can do telesurgery with these robots. The lights that are overhead, some of them have a camera built into the handle, and then you can also broadcast what's going on and the actual image that's coming from the robot itself and the scope uh, worldwide, and then people can watch on the camera as the surgery is actually happening, and also get the live feed of what the robot camera is seeing inside the patient as the surgeon speaks about it and things like that. Some of these advantages, like I was talking about, is you do get that image in 3 dimensions. The surgeon is sitting in what's called the surgeon's console, as you see here. That's what he's looking at, and when he's looking in there, he's actually seeing in 3 dimensions. So it is like the patient is open in front of him, and then his hands are down there below him, and that's where he's actually controlling the arms of the robot that you see the tech and the scrubbed in person back there manipulating and changing out instrumentation and things like that. So that's the actual robot itself, and then the cart off to the side that's got the monitor on it and all the boxes and everything we plug everything into. That's what's known as the patient cart, and that's where the computer system is and the monitor for us to watch and all that kind of stuff. Um, they also actually have special 3D glasses, and you can change that monitor on that tower to showing a 3D image, and you yourself as the tech can watch the surgery on the monitor in 3 dimension as well. So it's pretty cool. I used to be a naysayer on the robot. I was one of those old curmudgeons, like, why don't we just do it open? This is not right. Um, this is wasting too much money. But then I did some robot surgeries, and I was like, I completely see the advantage. That being able to see that image in 3 dimensions makes a world of difference. Um, and it also takes away some of the tremor of like a surgeon, right? Say, you're a new surgeon, right? You're just new on your own. You haven't done a whole lot of these kind of cases by yourself, and you're a little nervous, or you're a little bit older surgeon. You've been working for a long time. Hands aren't what they used to be. You're not as steady, right? It takes that stuff away because now you're just controlling the robot arm and it's just doing what you tell it to do, right? And then it was also that close replicate of our own movement and what we do with our own hands and how we manipulate tissue and things like that. Uh, that's a really good advantages of the robot, but the disadvantages, expensive. The robots themselves cost millions of dollars for all that machinery and instrumentation and stuff. Um, you got to have an on-site coordinator, so which means you have to hire a person who is your robot coordinator. That's their job, because these instruments and things like that, they have a limited number of uses. You can only use each instrument 10 times, and after that 10th time, the system won't allow it to work. It'll recognize it as you've been used too many times. It needs to be replaced. It won't activate it. So, and then they can only be sterilized 15 times before they have to be replaced. And the reason between the difference there is that maybe one got opened and just wasn't used. It was never actually hooked up to the system. So the system doesn't register it as being used. So that doesn't count against it just because it got opened. But you still have to re-sterilize it so you can use it later. So that's where the disparity in those numbers come from. And then surgeons have to go and have training on how to work the robot, and they have to have a mentor with them while they do their first few robot cases and things like that. So that takes time away from those surgeons and things like that. So things have to get coordinated. So some of the disadvantages, you have to basically dedicate one of your operating rooms to being your robot, because you have all that equipment and things like that. It's very difficult to store that equipment somewhere if you're not using it, and then pull it all out and get it all hooked up and boot through all of its updates and things like that if it's not constantly connected to uh, the internet system and things like that. So basically, one of your rooms becomes your robot room. Robotic training, right? You guys will receive this training. I'm going to be sending you out a link to the website and with the directions on how to go about going through this. There's online trainings and things like that. So when you guys are out at clinical, you can participate in the robot procedures, because a lot more are happening this way. So it's good for you to have these, and they'll go well on your resumes. Um, but they have labs, at their own facilities at like Da Vinci and things like that, Intuitive, where the surgeons can go and do training and learn different procedures and things like that. And whenever a new facility buys a robot and stuff like that, there's rehearsals that go on and training for all the staff and walkthroughs and stuff like that. Um, they even do what's called a dry run, where you don't open all the stuff, but you have all the training stuff there, and you have the room like laid out and set up how you want, and you bring in like a fake patient, and you just run through the whole thing and how it will work, and we try to see where the hangups might be, where we can improve, how can we can improve our timing of turnovers, because all of this stuff is new, and as far as how we got to take care of it, we got to that's that steep learning curve part, right? Is we got to get into that rhythm and how things can and where we can kind of shave our times and things like that, and but still get quality outcome and stuff like that. Um, but like supervised practice and the mentoring, feedback, it's all that communication piece now coming in, right? Where hey, this is our plan, right? We get on that same page with everybody, right? That's through these in-service programs and with the reps and things like that. And then we assign our roles. This is what we're going to do, and we go out and we rehearse it, we practice it, and then we look and go, okay, this is what we did good. This is what we need to do a little bit better. And this is how we can go about that. Boom, back to the start. Let's try again. So maybe another rehearsal if it wasn't, up to snuff the first time. Um, but these are like the different services that use the robot. There's the Mako robot that's giving those precise surgical cuts based on CT scans and things that the patient actually goes through. So all of these cuts and stuff are very specific to that patient. But that's an ortho, right? You can use the Da Vinci robot for doing valve replacements and things, for cardiovascular, general surgery, right? We're doing hernias or taking out a gallbladder, uh, uh, resecting the intestine, things like that. GYN, taking out, ovaries and cysts and uterus, urology, working on prostates, the bladder, doing nephrectomies. Neuro uses imaging and CT scan type guidance and everything like that, doing craniotomies and brain surgery. I think now they're starting to use some of the robots on their spines, so that they can get more accurate placement of their screws and things like that. So all kinds of, and even like tumor resections too. That's true. Tumor resections for the spine and the brain, but all kinds of cool, interesting things, and all of it happening through these real small incisions. So these patients, the recovery times are astronomically outstanding. So, but there's your components of that. The robot system is that patient cart, is that tower that's got all the boxes and the monitor, right? I'm sorry, that's the imaging system, right? That's got, just like for laparoscopic, right? That's that tower. It's got your light box, your camera box, your monitor. It's all for your imaging systems. The patient cart is the actual robot's arms and everything itself, because that's what's going to be up next to the patient and connected to the patient. And then the surgeon console, that's the little thing he was sitting in front of, looking into, where he actually controls the robot's arms and gets the 3D image of what the scope is seeing inside. Here are some examples of those instruments used in robot. It's the same as what you have in your open trays or what you have for the other endoscopic surgeries, right? You have scissors, you have graspers, you have things that cut and dissect, and there's even needle holders and little probes so that you can go in and kind of, push at tissue and see what things are, kind of hold some things out of the way. Your staplers and ultrasonic instruments, all the same kind of stuff. It's just going to be shaped a little bit different because we got to go down into these cannulas and trocars and things like that. So if you look on page, I'm not sure what page it is, figure 22-24, in your fuller textbook, you'll see all kinds of different instruments used laparoscopically, but you're going to notice that they all fall into those same categories of clamping and occluding, cutting and dissecting, grasping and holding, visualization and exposure. I talked about the lifespan of robotic instruments, right? You get 10 uses or 15 resterilizations. There is an online resource. You go to the Intuitive website, and you can go and find these manufacturer recommendations on how long things can go and how exactly they're supposed to be cleaned. And you can even print out like these big instructional things that you can hang up on the walls in decon, and it'll take you step by step on how to clean these instruments and things like that, because they are a little more complex, and it's not something that the decontamination techs had really seen in the past. But your general room setup for robotic surgery is the imaging system, and the patient cart is typically on the opposite side of where your instruments and your table and stuff are. I guess we're down here. This is anesthesia. So more over here, we're down near like kind of the foot. The patient cart, or the actual robot arms, is on one side of the patient. And then the surgeon console is always where the surgeon can just look over and still see the patient. They have to be able to see the patient. Usually what happens is the way that everything starts is the surgeon will scrub in initially for draping of the patient and making the initial incisions and placement of the trocars, and do what's called docking the robot. It's where they're actually going to connect those robot arms up to the cannulas that are in the patient. And then once that, and then put in a couple of their first instruments in the scope. Scope's always first, so we can actually see what's going on inside. And then they'll put in a few of their instruments so they can get calibrated. And once those instruments and everything are in place, the surgeon will break scrub, take off their gown and gloves, and then go get into the console and start the procedure. We stay scrubbed in and make out and change out instrumentation and things like that as needed. So these are the people that you usually have in the room. You've got your surgeon, their assistant, us as the scrub, and the circulator, who is sometimes also the coordinator. But you could also have the coordinator, the rep of the robots in the room as well. Typically, it's our job and the assist, if they have an assist, to be changing instrumentation in and out. If you're doing like a GYN procedure where you're doing like a laparoscopic assisted vaginal hysterectomy, the assistant will be the one who's below, removing the uterus through the vagina, and then we'll be the sterile person up top changing out instrumentation and things like that. So it takes a team to do all these. We also have to remember to stay within our scope of practice, because there's certain things that we cannot do as the tech. Like we can replace the instrument. The surgeon is the one that has to go in and actually grasp tissue, hold things off to the side. If there's something that they want us to use a different cannula for in one of our laparoscopic instruments to hold, they have to go in and hold it and then direct us, where to take it from and things like that. So it's usually best to have the assist do the assist things, just to stay out of any kind of trouble. But sometimes there is no assist. It's just you and the doc, and you're the only sterile person. So you may need to kind of do what you need to do to get the procedure done. But that is it for minimally invasive surgeries. Let me bring up stuff to study for on the quiz. So for your quiz, understand uh, Maslow's hierarchy of needs and how it's kind of set up, what the different steps are, right? Um, know what patient-centered care is and how it applies to the operating room and to the team in the OR. Know your different breakdowns of like pediatrics, uh, geriatrics, bariatrics. How to delineate the different um, groups within even those ranges, like the breakdown of the pediatrics and things like that. Um, know about nutrition, malnourished patients and how it relates to kind of healing, for those patients, right? Know about kind of like comorbidities, those other diseases that a patient can have, like diabetes, things that they didn't come into the hospital to be treated for, but they still have to live with it. Right? They've got like high blood pressure, diabetes, or congestive heart failure, emphysema, and we're, somebody who has emphysema and we're doing a knee scope on them, right? Those two things aren't related, but it can affect their healing. Right? Yeah, manage those good. Um, know why about thermal regulation and why we do it. Uh, know about, let's see, that's how to clean the endoscopes, kind of the steps that goes through that. Right, I just kind of got over that. Right, the two sinks, you have one with the enzymatic cleaner, the detergent soaking in there, and you're flushing and cleaning all that out, or you're going to move it over to the next sink and flush it all out with the water, saline, and clean it all out, and then you're going to leak test it. Right, the leak test must happen to all endoscopes. Has to happen. Um, know the difference between the types of scopes. Is it a endoscope? Is it a laparoscope? Is it a arthroscope? Right, depending on where it's going, that's the kind of scope it is. Remember, endoscopes in the mouth and up from below, laparoscopes in the abdomen, arthroscopes in joints, hysteroscopes in uterus, cystoscopes in bladder. Right, remember all those. Um, know what surgical clips are and how they're used, why they're used. Know how to check for damage on your laparoscopic instrumentation. Know the parts of the camera, the like endocoupler, the focus ring, things like that. Know about safety of the fiber optic light cord. Know how fogging happens. Know about the trocar cannula system, what it is, what it accomplishes for us. Um, why we put patients in certain positions, for what kind of procedures would we do that for. Um, know the difference between a minimally invasive surgery and an open surgery. Know what pneumoperitoneum is and how to accomplish it, one of the steps or one of the techniques, like using the Varus needle. Know what insufflation is and know what distension is. And then for your matching, be able to pick out between whether something is minimally invasive surgery, endoscopy, or robotic. Okay? It's going to just give you like a little statement, and you have to decide whether that fits into one of those three things. Is it minimally invasive surgery, robotic surgery, or endoscopic surgery. And then, so that'll be 4 questions worth of matching. And then you're going to have 6 questions of matching where you're going to have to decide whether something is an instrument, it is part of a technique that is used, if it is part of the imaging system, or if it falls under the category of insufflation. Okay. So like, if it were to say something like accomplished through a Veress needle, is that a technique, an instrument, part of the imaging system, or part of insufflation? I would say insufflation. Because, however, you are doing a technique, you're doing the saline drop test, but you're insufflating through the Veress needle. So just keep that one in mind. Um, Again, apologies for this coming out so late. Hopefully everything is good to go, and we'll hit the ground running again when we get back in on Monday. All right, you guys enjoy the rest of your weekend, and we'll see you tomorrow.